We're gonna record it just because I know many people are ATS, and that way, if anyone wants to watch, they're here. They have a chance. Okay, let's do it.
Just put it, you can just put it aside, that's fine. Yeah. All right, hi everyone. We are, as you all know, the U Chicago Fellows. I'm Gaurav, Monica, and Nee. Yeah, so we're gonna just go ahead and get started then. Let me just go to the next screen here. Okay. So no conflicts of interest or disclosures here. So we're going to kind of get into presenting the case here. It's going to be this particular patient we chose is kind of the data is from over a span of a few years. So we're going to start with just the initial kind of evaluations and then the follow-up kind of when we became more involved in fellowship this year. So this is a 53-year-old female, has a history of depression, anxiety, and GERD. She initially was referred for a PSG, given concern for OSA. So she had endorsed her primary care physician at that time that she was having snoring, witness apneas, and excessive daytime sleepiness. Now, in terms of the daytime sleepiness, it had been going on per the notes from back in 2014 when this was done. It had been occurring for about 20 to 15 years. But this was the first time she was really evaluated for sleep apnea or sleep disordered breathing. And at that time, there might have been some societal, like environmental things that had triggered this. So she had, there was a passing of a fiance. When this started, she had moved to a new home, and then she started working in a new job as a school teacher. And she had kind of been managing her symptoms on her own until this initial workup was started. So her primary care physician referred her for an in-lab polysomnogram in 2014. And just to kind of quickly give you the data from that, the initial polysomnogram was November 2014, had an AHI of 10, overall RDI of 13, REM RDI was 22, and then the oxygen in the DR was 87%. Now, given that there was more prominence of the sleep disordered breathing in REM and her symptoms of, at that time, her Epworth sleepiness scale was above 10, there was some hypersomnia. So they wanted to treat her for the sleep apnea, given that she appeared to be very symptomatic. She had the PAP titration study done separately. That was done in December 2014, a month later, and that showed successful CPAP titration and 6 centimeters of water. So she had her PSG done first, and then she followed up with our sleep clinic, after she received her machine and was on the therapy for some time. So her visit with our sleep disorders clinic was on September 2015. And they essentially continued her with the CPAP therapy, given her symptoms and hypersomnolence, like I said. And then in a year later, that was the next follow-up visit. She basically had persistent symptoms, and in her compliance with the CPAP, again, we have a little bit more limited data from then, but it seemed to be kind of this poor, fair compliance to CPAP overall. But then she had reported to to the sleep physician at the time that she was now having hypnopompic sleep paralysis, hallucinations, and then possible cataplexy. So these were not symptoms she had endorsed before, of course. This was kind of new. And I'm not sure if this is something she had been having for many years, and this is just the first time she brought it up, or if they were truly new. But she had also endorsed these symptoms of weakness in the arm and buckling of her legs with laughter and strong emotion, which was suggestive of cataplexy or possible cataplexy. So that was kind of something new and under reassessment. So we were trying to make this somewhat. Can
I ask why? What was it possible about the cataplexy that was not? We don't know, right? Was it really questionable, or was it that it was atypical, or we just because sometimes maybe we didn't ask enough questions.
I think it was documented later in Nee's note, actually, that she had like buckling of the knees She was a school teacher, buckling of the knees where she would have to sit down and would have developed tremors.
But I think like from a previous note, it doesn't have much of documentation in terms
From,
of
yeah, we didn't find that.
cataplexy at that time. in
Yeah.
2015.
So we didn't have the description earlier, but late now, that when we reevaluated her again, it was, it seemed like the symptoms were typical.
Yeah.
And it was followed after emotional event or laughter, yeah.
Sounds good.
Yeah.
So for the fellows, what how do you ask about cataplexy? Can you buy something for me? Sorry, I'm trying to get lunch. And also I'm sending the link because I sent the wrong link to the chat. Oh my God. 1 second. I'm not very good at multitasking. Okay, now everyone should have the correct link. Ronelle is here. Thank you, Ronelle. Okay, go.
So I
So,
guess
okay, so who are the fellows, Aria?
I usually ask about essentially knee weakness with strong emotions such as like happiness or laughter. Do you notice that your knees get weak? So really just with strong emotions, and then essentially they crumple to the floor, or it's not necessarily that they're like falling asleep, kind of just losing control of their body.
Okay, that's good. What other subtle ways should you be asking? Who's talking? Is it me? No. Oh my God, sorry. Yeah, so that's it. That's the good initial question. And I've learned this from Dr. Herdigan actually, and from Lurie. So what can you miss with that? Too,
like stroke-like symptoms or
No, specifically about cataplexy. Ever in your life, during a moment of extreme emotion, laughter, you're really upset, have you felt weak, like you had to sit down, couldn't stand up, eyes drooped, or had your tongue stick out? Okay, let me admit 3, sorry. So what you're seeing there that Ted brought up is that there are subtle signs of cataplexy that you will miss if you only ask about knee buckling. So some of those are, let's say you're really excited about something, whether it's upset or laughter. Do you have trouble speaking? Do you feel like it's hard for you to articulate the words? Do you feel like your head drops? Do you feel like your arms, it's hard to move your arms? So for some patients, it's not as obvious as knee buckling and falling to the floor. So it may have been missed in those cases. Anything, Dr. Herdigan, I may have missed?
Yeah, sorry, I'm not on camera. The fellows gave me this amazing pastrami sandwich. And, well, I've got mustard all over my face. But,
That's okay.
But I digress.
Now I'm hungry.
What I really wanted to go back to, and we've actually, as you remember, we've been working with EnsoData. And EnsoData has been working with Dr. Mignot on sleep polysomnographic characteristics of narcolepsy, especially type 1 patients, which sounds like this patient's becoming a type 1 patient. And their sensitivity and specificity just through analysis of the overnight PSG is actually higher than the MSLT in terms of diagnosing type 1 patients with narcolepsy. So do you have the hypnogram from the 2014 study? That was, I guess, my question. Because there are unique characteristics in overnight polysomnography that can help diagnose narcolepsy.
I think we included the PSG, but not the actual hypnogram.
Oh, major important detail.
Well, so what they're seem to be showing is they look at arousal patterns, both REM, non-REM arousal patterns, and fragmentation of sleep. And typical type 1 narcoleptic patients have very fragmented sleep. As sleepy as they are, of course, the latencies to non-REM and REM sleep are important, but it's the continuity of sleep that seems to be an important characteristic.
I see.
I'm going to go back to my pastrami sound.
Go back. Thank you so much. Ronelle, anything you want to bring up? I know you're in the middle of like picking up your kid too, so. Or I don't know if he's there. I know he was super busy and he was trying to help. Okay, go on.
So I mean, our next slide, we kind of got into this already, but like what we're trying to make this a little bit more interactive, what the thoughts are where we are right now. So so we know that the patient had sleep apnea, right, overall mild in the past, and now she's endorsing these symptoms that are, suggestive of possible narcolepsy. I guess, what are your thoughts? Like, what are the thoughts on what we should do next, or if there's any different, things we should be looking at?
And you're asking these questions to whom?
To anyone, fellows or attendings, or what? Yeah.
Okay, Victoria. Ted. Ted and Mike, you're on.
Sorry, I can't say I'm having pastrami, but I am eating.
That's
So it
okay.
sounds
This
like-
conference you can eat with all the mustard on your face and it shouldn't be a problem. It's informal and
she
it's
has
during
some
lunch. We expect
associated
lunch.
symptoms and things like that. Maybe go for a PSG MSLT if we haven't already had that on file.
Okay.
So I think the patient was diagnosed with obstructive sleep apnea and haven't been compliant with treatment. I would say like patients should be started treatment for obstructive sleep apnea first, and then we can do a PSG and MSLT.
That's a good point. I think sometimes we're like, oh my God, this is clearly not only sleep apnea, but sometimes even when we want to, like clinically, let's say there is a very high concern for narcolepsy, sometimes the insurances will deny if you haven't at least tried CPAP and they're still symptomatic. I've had that happen to me before, and sometimes you have to do a peer-to-peer if you're really concerned. Thank you too. Okay, go ahead.
And I think that's a good point to bring up though, because this patient, she had mild OSA, right?
Yep.
So, and not a lot of hypoxia. She, was clearly having these symptoms that sound like possible narcolepsy and comorbid narcolepsy, but if it was the same patient who had very severe obstructive sleep apnea and hadn't been treated, you might want to get them on PAP therapy and optimize that with the plan still to do the PSG MSLT after. But with mild sleep apnea, do you really need to take that step? Thinking about that.
Okay, go on. Let's move fast.
Okay. So
I know I'm the main impediment to moving fast, but I'll keep it in mind.
okay. So the patient was on CPAP therapy at that time. Again, compliance wasn't great, but I think because like we said, because it was on the mild range, they wanted to proceed with a PSG with an MSLT following, and then the 2 weeks of actigraphy before both of those studies. So what I guess I just took a screenshot of the overall MSLT that she had. What are some thoughts about what we're seeing here?
Gaurav, you have to call people out. I'm very uncomfortable with silence. So just say names.
Okay, so
Any of the fellows from like Northwestern? Here.
Okay. I'll just keep going. So
Okay, Ted, no, Ted is writing in the chat. You have to keep an eye on the chat. Good point, insurance
Sorry.
treatment. Where did the eyes go? I got
I'll
them.
see him now.
See, they changed the eyes and then your brain doesn't work as well. That happens to me when they move my thermistor and my pressure transducer. But sometimes the board will have it in different places. I just want to highlight that it is important.
So I see some reasonably low chin tone, mixed frequency, low amplitude for the EEG. Maybe artifact versus maybe eye movement on the left, but no clear rapid eye movements for me. Probably around.
yeah, so this was, I mean, you can see on here that, the patient did have decreased sleep onset latency, and then there were 4 nap opportunities to nap on this PSG, and then of course 3 of them we did have, we did see a sleep onset REM period for 3 out of 4 of those naps. So then
This is our MSLT, right?
Yeah.
So so just to give a little bit more information, because I think when we talk about the MSLTs, right, we have to really take into account all the different factors that can affect it, right? So I think just by saying that, and we'll get to this a little bit later, just by saying that this patient had 2 or more SOREMs on MSLT, right, that can happen for a variety of different reasons, not just narcolepsy. So one thing to note, again, this is from the initial workup in 2016 that she had done for narcolepsy. So that MSLT actually, for insurance reasons or whatnot, there was no preceding PSG that was done. It was just the MSLT. And
The
so
insurance denied the preceding PSG, by the way. Don't get bullied. Don't let yourself bully by these guys.
so the sleep onset latency was about 2.5 minutes with 3 SOREMs, which I already kind of said. And so the patient really had actigraphy 2 weeks prior to the MSLT, and they used the data based off of that to kind of make a clinical judgment. Now, the patient was informed to use her CPAP machine for the weeks up, make sure she's using it consistently for the weeks up to the sleep study. And the actigraphy really revealed the night before the PSG that she had slept for 5 hours and 22 minutes, of which the patient, we could get it on the compliance data, used the CPAP machine for about 3 hours. So again, not ideal, sleep the night before, and didn't use, the CPAP for the whole duration of sleep, but just as a possible factor that could influence the result.
Now, what do you think? This is for anyone attending SURF or fellows or what do you think of the actigraphy saying 5 hours and 22 minutes? What is the caveat? Because the estimated onset latency is 0. Mean estimated on sleep onset is 16. So what do you think? Based on what Dr. Herdigan mentioned.
Like her fragmented sleep?
Right. If she has a lot of fragmented sleep, then maybe the active watch is assuming that she's awake because there may be a movement, but she may be going right back to sleep. So that's why it's so important to have a PSG.
Yeah.
Right. Okay.
Did she have sleep diaries as well to go with the actigraphy?
We usually do them. Unfortunately, this is the only data I could pull from her, was just this summary thing, but I couldn't find the sleep diaries for her, unfortunately.
Yeah, because I think this one was from 2016, so
Yeah.
I don't know.
If we still have the results.
And that would have been helpful, right? Like if she says she slept 8 hours. I mean, obviously you always have these weird patients that want to malinger that they have hypersomnia, but she's not one of those. So, well, who knows? Anyway, sorry, I've been burned. Go ahead.
Okay. So just to kind of review, I know we're all towards the end of our fellowship year, but we're using the ICSD criteria here, in terms of narcolepsy. We know that MSLT can be used as part of the diagnosis, looking at the SORM periods, sleep onset latency less than 8 minutes. And of course, patient having symptoms of daytime sleepiness for 3 months. Okay. So just more about the MSLT, this MSLT latency test, I think.
Yeah.
You want to talk more about
So
this?
we know that it consists 4 to 5 naps spaced 2 hours apart. And it's important to be that the MSLT is preceded by an overnight PSG with what we just talked about to assess for any other causes that could contribute to daytime sleepiness, like the fragmented sleep. And by ICSD-3, I think it's in that criteria that you need a minimum of 7 hours of time in bed with at least 6 hours of sleep. Now, that's not saying that 6 hours of sleep is adequate per se. It's just that in patients with narcolepsy, due to the fact that they have fragmented sleep, that 6 hours of sleep for them is still a good threshold compared to ideally you would want at least 7 hours of sleep. And then this is also accompanied by 2 weeks of actigraphy and or a sleep diary for more, I guess the sleep diary is more subjective, but then the objective data that we're seeing on actigraphy for their sleep patterns. And I think when we were just going through fellowship in terms of understanding why it's like 2 weeks of the actigraphy, it's, for example, in patients with shift work, you want to see that they have consistent, sufficient sleeping times on their on weeks or like their on days and their off days. So it gives you more objective data on what their sleep patterns are while they're working or not. For example, that's just an example in that population of patients.
And I think the guidelines say overall in terms of the time to sleep, like ideally the patients sleep, 7 to 9 hours or so, but they do reduce the minimal threshold to 6 for those who may have actual narcolepsy with fragmented sleep. So that's why the cutoff, like Monica said, is lower for that.
So this figure is actually taken from a study that was done in 2020 with Dietman et al. And it's basically trying to explain the validity for an MSLT and a PhD in patients with narcolepsy and without narcolepsy. So we all know that the classic or like the gold standard of trying to evaluate for this is an MSLT. But there's been there's often been questions about whether there's a high enough sensitivity or specificity associated in order to make the correct diagnosis in patients with narcolepsy. So this figure is showing, so this was a retrospective study that was done I think in 2020 with 370 patients. And I think a few people were excluded, but they took these patients and broke them down into 5 different groups. So you have your narcolepsy type 1, the 2s, this is idiopathic hypersomnia, then the non-organic hypersomnia, and then insufficient sleep syndrome. And they took a look at, they retrospectively took a look at the data to see what the mean sleep latency was in patients on an MSLT and what a mean REM latency was on an MSLT, and then also compared it with the patients on their PSG. And what we see here is, for the mean sleep latency and for the mean REM latency, it was significantly shorter. So this is about 2.7 in narcolepsy type 1, and this is only a little bit above 5. It was significantly shorter compared to the other groups. And then same on the PSG too. And one important thing is that an occurrence of a SORM, so a SORM period during a nocturnal PSG, was highly specific for narcolepsy type 1. So, and then let me see. Any questions about this figure? Okay. So, and then it also looked at, again, this study looked at the sensitivity and specificity. And if you're looking here, patients with 2 or more SORMs on both an MSLT or the first one from a PSG, 99 of the 110 patients that were diagnosed with narcolepsy type 1 showed that, demonstrated that they had greater than 2 greater than or equal to 2 SORMs on the MSLT or the PSG. So that's pretty high sensitivity and specificity. But as you have more SORMs in the MSLT and in the PSG, the specificity did go up, but at the expense of lowering your sensitivity. And so when we were interpreting this data yesterday, is that it is still more specific to rule in narcolepsy type 1, but it doesn't, with the lower sensitivity, guess the way to interpret it is that you can't rule it out also, just because they have more than 3 SORMs. Because, and it's an important, the reason why we make this point is if they have more than 3 SORMs, the question starts to become, is it truly narcolepsy type 1 or a different disorder? Like or any circadian rhythm disorder and things of that sort.
Wait, go back. So if there are more than 3 SORMs in an MSLT,
Yeah,
then the sensitivity drops, but the specificity is very high,
yeah,
meaning that it's most likely narcolepsy. Am I misreading this?
no,
That's correct.
that's correct. Yeah, because I
Okay.
think some other literature review we did was, it was questionable whether having 3 or more SORMs, if it doesn't always mean narcolepsy type 1. So we were like, oh, let's look at the literature. And we found this study because it could be insufficient sleep syndrome. It could be like any circadian rhythm disorder. So that those are differentials they want you to consider if there's 3 or more SORMs. But most often the specificity just gets really high. And then here again,
I see Ronelle. Hi, Ronelle. We cannot hear you though. At least I can't.
There we
Just
go.
checking.
Can you hear me now?
There we go. Yes.
Yeah, sorry. When you called me out earlier, I was trying to chime in, but because I dialed in, I have to unmute 2 different places in order to be able to. Anyway, so I would chime in about the circadian rhythm bit. Yes, if you're having, you should always consider circadian rhythm disorders in any case, whether it's 1 or 2 or more sleep onset REM periods. But what you're going to want to think about are when are those SORMs. If they are in the first 1 or 2, you're going to think more about delayed or a non-24-hour rhythm disorder. If you are considering having, if you've got 3 or more, you should be thinking either of this, somebody's so delayed that they're just sleeping during the day, but they should be more awake at night, or a non-24-hour rhythm disorder. And that's one of the other reasons why to do the actigraphy and to get that detailed history, because you're going to want to see what the circadian pattern is. And I know you brought up shift work, which is important, but it's not just about the shift work and the misalignment induced by that, but it's also just any other circadian rhythm disorder.
no,
Super. Thank you.
thank you. So yeah, and I think this is, again, we're taking a look at 75% of the patients in the narcolepsy type 1. So had 3 or more SORMs. So that's just, again, telling us that there's a lot that this is a good correlation in regards to specificity in patients with narcolepsy type 1 versus the other groups here. So as you can see, 3 or more SORMs in the other groups were not as highly observed compared to the narcolepsy type 1.
So, and I kind of touched on this briefly, but the things to always consider with the MSLT are the limitations. So considering medications that patients are on, Of course, we talked about comorbid sleep breathing disorders, and then we've talked about circadian rhythm disorders. And I think, there's a lot. Obviously, this chart here was taken from one of the studies I was looking at, and there's a lot of medications, right, that can affect sleep architecture, causing REM suppression. And I think one thing to be aware of, I actually had a MSLT I was reading with one of my attendings, Dr. Lee, earlier this week, and actually a patient had an MSLT done and had multiple SOREMs, had actually 4 out of 5 of the naps. But we had found out this is why the sleep diary is important too, because the patient noted on her sleep diary, she stopped taking a stimulant and 2 antidepressants 3 days before the study. So not only do these cause REM suppression, but then you have to worry about REM rebound, right? Did this patient rebound because now they stopped their medications abruptly? I think our practice here, that from what I've learned thus far is, if we're going to stop the medications, we really should stop it for a good 2 weeks, or you just continue it and you would accept that limitation if the patient can't stop those medications. So I think that's just something that's important to note for any kind of case that you're doing an MSLT interpretation. And we kind of talked about this already. So for her, some things that could have impacted the MSLT, right, is that there was reported, right, per the actigraphy, and I know that has its limitations too, we talked about, but there's shorter total sleep time the night before, the history of non-compliance with CPAP and not really optimized in that regard. And then she did have some, and we'll kind of get to this in the future slides, but she did kind of have endorsed these, per the documentation, their sleep, not a very stable sleep schedule, I would say, going to sleep at various different times during the week and getting up at different times. So maybe that could have had an effect as well. So now where we get involved presently was that she was lost to follow-up for about 3 years with her psychiatrist, because she's following them for the depression, anxiety, things like that. Referred her back to sleep medicine, given the persistent daytime sleepiness. It's becoming pretty impactful in her day-to-day activities. She actually had to take 1.5 years off from work due to excessive sleepiness, because of course she was a school teacher. You can't really be falling asleep in class and things like that. And honestly, when she followed up, she was using her CPAP machine, and her compliance was actually better than it was in the past. And she was still having all the symptoms we discussed before, both from a sleep apnea standpoint and from a narcolepsy standpoint. Now, one thing I will note before we continue, I forgot to mention, was back in 2016, they clinically suspected narcolepsy, and they actually offered her medication to try at that time, but the patient declined. I think she thought her symptoms weren't that significant, and she was worried about the side effects. So she was offered it, but never started the medication, just as a side note. In terms of her sleep habits, again, this is more presently, really didn't endorse a set bedtime, falling asleep around 9:00 p.m. Oops, I'll try to make this smaller here. Okay, and then fall asleep around 9 p.m. We'll wake up often around 11 p.m. and then we'll go back to sleep with CPAP. And then may not always be starting to sleep in her bed, falling asleep, on the couch or in front of the TV, then moving later on into the night. Which is not uncommon with a lot of our patients. Sleep latency was 5 to 30 minutes. Wake time varied, but she had to be up by 7:30 to go to work. Wakening up frequently at nighttime, at least 3 to 5 times, sometimes able to fall back asleep, sometimes not. And then she was napping at least once a day. And then of course, dozing off at work, like we talked about, grading papers, and didn't report any significant caffeine use. In terms of her review of symptoms, I'll make this quick. So we kind of already talked about this, honestly. This is all the sleep disorder breathing symptoms, and then we talked about the sleep paralysis, hallucinations, and then the cataplexy, and we already talked about what that kind of was like for her. So vitals were stable for her, BMI was 22.
So by the way, her cataplexy was actually subtle. She would get upset, and then her arms would feel funny and like weak, and then she knew that she had to sit. So it wasn't as the dramatic, buckling of the knees, falling to the floor.
Right.
Okay. Exam is fine. She's thin and SVT.
Yeah, one thing in the interim that happened, because this is going to become important in terms of medications that we chose for her, but she was admitted for an SVT episode, started on beta blocker therapy, metoprolol. And then she did have a family history of narcolepsy, and her brother Epworth was 23, which obviously is very significant. So in terms of what we would do next, so for her when we started her appointment, she was having issues with machine data transmittance. At that time her machine was over 5 years old, so we actually had her undergo a home sleep study test, which showed mild OSA, again similar to the past, moderate in REM, moderate in the supine position, and technically it was seemed to be a valid study with 6 hours of sleep time, 20% of REM seen. So we ordered her a new machine, but a lot of the confounding factors that were present back in 2016 were still present here as well. So we actually proceeded with doing a lumbar puncture instead, and that was to actually look at an orexin level. So just going back to the criteria here for narcolepsy, I just bolded the second part of it. See it, and you can use an MSLT, but you can additionally use and this is for narcolepsy type 1, of course, CSF hypocretin concentration less than 110, or less than 1/3 the mean values obtained in normal subjects. So we sent her for an MSLT, we sent her for a lumbar puncture. And it resulted actually that her orexin A level, hypocretin, was less than 50. Which I think was helpful in her case. Again, we already kind of had the suspicion of narcolepsy and whatnot, so it wasn't completely surprising, but this was the result we had of that. And we wanted to talk a little bit more about just the neurobiology.
No, we're not gonna do this.
Okay. So
No, let's see. Okay.
So this was a study by Mignon in 2002, and it was just taking a look at the importance and the role of orexin levels that used to make the correct diagnosis in narcolepsy. I think the experimental group had about 274 patients, and then the experimental was 296 healthy patients. And then that also included patients with neurological disorders that but did not cause fragmented sleep. So when I was looking deeper into seeing which kind of patients those are, so right here is this right here, patients with like encephalopathy or Guillain-Barré, and I think there was another group of patients that they qualified or had trauma. So I guess they didn't have, those were qualified as patients with neurological disorders, but without any fragment, at least major disturbance in sleep patterns. And if you take a look at when the intervention that was done was a venipuncture, they wanted to look at the frequency of positivity in the HLA DQ B10602 allele, and then also and then they did the analysis for they did a CSF lumbar puncture to check their orexin levels. And if you take a look at the stat diagram, you have your controls, and then you have your narcolepsy, and then other sleep disorders. So obstructive sleep apnea, restless legs, and insomnia. The ones with typical cataplexy had the most, the threshold for it was less than 100 or 110 to 100. There was way more prevalence here for patients with typical cataplexy. And then if you look at your control arm here, patients that were either whether it was done in daytime or nighttime, or even patients with neurological disorder, they were above the 200 cutoff. So this study was one of the first studies that was done that actually confirmed and showed objective data for the role of the allele sequencing and for in terms of the frequency of positivity for the allele, and then your direct assay for the cerebrospinal fluid. And then they ended up calculating the sensitivity and specificity of low hypocretin levels in the 110 for a orexin level less than 100, and the sensitivity and the specificity was pretty high compared to the patients in the control groups. And this is the same thing here when we're talking about the increased HLA DQ-B10602 frequency. As you can see right here, there was much higher frequency positivity in patients with narcolepsy with typical cataplexy. And then you have your numbers without cataplexy. idiopathic hypersomnia, that was interesting, and then your atypicals, like cataplexy. So still higher numbers compared to the other disorders.
It's funny because for a while I was like, they should remove this hypocretin thing from the ICSD-3 because it was hard to get, right? It's hard to get. Like Lindsay just asked about the insurance approval for the LP. Yeah, they approved the LP, but not the PSG.
Yeah.
Then, you have to send to Mayo. It's an invasive procedure. Not every place, can do an LP and send to Mayo. And then I think I sent to the chat, to the Chicago, like the Sleep Chicago chat. And Dr. Atarian asked whoever, has been working on this with the ICSD-3, and I know Ronell has been very involved in that too. And they're like, no, it's here to stay. I'm like, okay. Or like, and now I see why, right? Like you have these very difficult cases. And this is the patients that is very helpful, I find, in type 1 like narcolepsy.
So now we question about what about intermediate levels of orexin?
So there's this study that was like a multi-center studies and with like Italy and Stanford, where they look at about like 1,600 patients that underwent evaluation for narcolepsy between 2007 to 2019. So from this 1,600 patient, they looked specifically at the 40 patient who have a positive MSLT and an intermediate levels of orexin, 110 to 200, and they could compare the clinical, the biology and the neurophys features of these patients with and without cataplexy. So from this study, they found that patients with cataplexy have more REM sleep dysregulation, higher dream activities during daytime naps, and then as well as like higher SORMs when they look at this patient. They also have a more positive HLA DQB1 haplotype on these on patients who have cataplexy comparing to the one without. So there are also like case reports on patients who have a normal MSLT, who have like cataplexy, but has an initial normal MSLT and the initial CSF hypocretin levels, but then they gradually developed excessive daytime sleepiness, worsening of daytime sleepiness, and then they repeat the orexin level, and it came out to be below 110. So this kind of bring up the thought of like, is this a progression of narcolepsy when you initially have a normal orexin level and eventually it became low later on in life? Or is this like a testing where we need like a better testing to diagnose patient with narcolepsy?
Yeah. I mean, just out of curiosity for anyone that's on here has in regards to repeating MSLTs, I mean, has there in your practice, like, have you had to do some, like keep repeating them on a patient or? Or if anyone else other than Dr. Lastro while she eats it.
I have had to repeat one or two, and it just depends on the situation and if the you're questioning. I mean, if it's consistent with the clinical syndrome, that's fine. I mean, if it's mostly consistent with the clinical syndrome, you're probably fine. But if you're questioning it, or if you think it's a false negative, more so it's a false negative, or something happened on that MSLT, then yeah, I think you have to repeat it. But your challenge is getting it through insurance.
Yeah.
And you have to make a very clear justification.
Yeah. Okay.
Wherever they're going.
You may also need to repeat it even if you think it's clinically narcolepsy.
Yeah.
And then the insurance is denying you medications because you don't have the MSLT with the 2 SORMs.
Yeah.
So sometimes
I didn't look to see if they have any.
Um,
kids or things.
I've encountered that situation where like we know it's narcolepsy. There may have been something off with the testing, but the insurance will put the foot down and not approve any of the newer medications because you don't have the two.
Had a pick in the past, no problem.
Okay, we have to go.
Surgery on your.
It's
arm,
one.
A pacemaker.
Okay, just-
Sorry, guys.
No.
Oh, did you, I have like one more slide.
Yeah, go ahead.
So just the last minute, so her hypocretin level was way below 110. We did end up starting her on medication. She was hesitant, especially because of the SVT she was admitted for. We ultimately took a look at her pharmacological therapy, couldn't do the stimulants because of the SVT, couldn't do Sunosi because it does have some cardiovascular effects dose dependently. And then she refused sodium oxybates, and then she also refused pitolisant and venlafaxine due to combined therapy. So we ended up doing weight kicks on her and obviously titrated her up. It's just for this one, we're also going to have to monitor for QT prolongation, especially if she's on a combined medication that can also increase her QT. And especially given her history of SVT. So very close monitoring. And then this last slide was the new extended release, once at bedtime oxybate, sodium oxybate it's in its final stages of FDA approval, Lumraz. I think it should start rolling out end of June. And the only really big adverse effect or side effect that can develop, and it was only shown in less than 5% compared to the control group, was nausea, dizziness, headaches, and I think maybe insomnia or vomiting. I'm sorry. So nausea, vomiting, dizziness, enuresis, and headaches. So this should start rolling out in June to help patients with narcolepsy for a one-time. We have a question.
Need to leave something. Leave a pair.
Strong work, guys.
Yeah.
I think.
You
guys knock out those two things.
Any questions, comments from the group?
We'll go drain that guy. It's the.
Thank you so much for all of those that
Oh, yeah.
made it. Thank you, Renelle. Yes, Lindsay.
I
Sorry.
was just saying, great case.
Yeah. Thank you.
Great job.
Thank you.
Bye, guys.
Bye.